Our lecture today is about male infertility. Infertility is defined inability to conceive after 1 year of unprotected sexual intercourse, and it affects about 15% of the couple. In the ancient time, previously, the female was blamed as the cause of infertility in every case of infertile couple. But nowadays, the causes of infertility is 30% due to male and 30% due to female, and 30% both of them are shared in the cause of infertility. 10% still unknown, idiopathic, or probably attributed to autoimmune disease or autoimmune infertility. In the management of male infertility, as management of every other case in medicine, start with the history. The history is the cornerstone of evaluation. In medical history, if the patient have fever, systemic illness, diabetic, cancer, infection, genetic disease, cystic fibrosis, Klinefelter, history of post-pubertal moms, and as you know, moms to cause infertility should affect the testes bilaterally in post-pubertal age. Surgical history, if there is history of cryptorchidism, herniorrhaphy, trauma, torsion, pelvic, bladder or retroperitoneal surgery, transurethral resection of the prostate. Fertility history is important if you had previous pregnancy from present or other partner. Duration of infertility, previous infertility treatment, female evaluation is also important. Sexual history, timing and frequency. Family history, if there is cryptorchidism, history of hypospadias, midline defect, Carter syndrome. Medication history, if the patient taking nitrofurantoin, cimetidine, sulfasalazine, spironolactone or alpha blocker. Social history, if the patient is alcoholic, smoking, cocaine, anabolic steroid. Occupational history is also important. If he is exposing to ionizing radiation, chronic heat exposure, aniline dye, pesticide, heavy metal, lead. Physical examination start with a general examination, hair distribution and gynecomastia, which reflect the effect of hormone or any chromosomal abnormality. Genital examination, examine the testes, size, consistency. If there is induration, tenderness, or cyst of the epididymis, examine the epididymis. If there is cyst, presence or absence of vas deferens. If there is varicocele, especially detected at Valsalva maneuver. Penile abnormality, if there is hypospadias, cordy. Digital rectal exam to assess the prostate and seminal vesicle. Laboratory investigation start with general urine exam. If there is infection, glucosuria, hematuria. Seminalysis is the cornerstone of the investigation of male infertility, which reflect the well-being of the patient and the genital tract. Is the primary source of information on sperm production and the reproductive tract patency. Sample collection, sexual abstinence duration, liquefaction, should all these included in the seminalysis. Should be examined first, 1 hour transit time and at body temperature. WHO consider the minimal criteria for normal seminal quality. The volume is 2 to 4 ml. Concentration 20 to 40 million per ml. Motility 40 to 60%. Progression score 2 on a scale from 0, immobile sperm or no movement, to 4, excellent progression. Morphology more than 30% or more than 4, Kroger normal form. Computer-assisted seminalysis used to remove the subjective variable in the manual analysis, but it can overestimate sperm count by 30% in the presence of contaminated cell, immature sperm, or leukocyte. Then the motility is underestimated because the motility is percentage of the total number of the sperm. Seminal fructose and post-ejaculate urinalysis both are used to evaluate small ejaculate or unejaculate. Fructose absent in semen if there is seminal vesicle agenesis or obstruction, And retrograde ejaculation can lead to small amount of ejaculate. The causes of retrograde ejaculation, as you know, diabetic, probably medical therapy like alpha blocker, pelvic, bladder, and retroperitoneal surgery, which lead to retrograde ejaculation. Hormonal assay, evaluation of pituitary gonadal axis, provide information on the state of sperm production, hyperprolactinemia, gonadotrophin deficiency, congenital adrenal hyperplasia, follicular stimulating hormone and testosterone assay recommended in severe oligospermia. What we mean by severe oligospermia is density less than 10 million per ml. This combination detects 99% of endocrine abnormality. Luteinizing hormone and prolactin hormone level may be obtained if testosterone and FSH are abnormal. Thyroid hormone, liver function test, and other organ-specific tests obtained if there is clinical evidence of active disease. High FSH, more than double, plus low testosterone in azoospermic patient, it means this is due to testicular failure. On the other hand, if the FSH is low and testosterone low, it means hypogonadotrophic hypogonadism. While if both of them high, FSH high and testosterone high, it means due to androgen deficiency. Adjunctive test indicated if initial evaluation failed to lead to diagnosis and if they changed the patient management. Semen leukocyte analysis, biospermia more than 1 million leukocyte per ml, should differentiate from immature sperm by special stain like Papanicola, peroxidase stain, or immunocytology. Biospermia present in infection, immune sensitization, and low-grade toxin like cigarette smoke and alcohol. Anti-sperm antibody test, autoimmune infertility may occur when blood testis barrier is broken and body is exposed to sperm antigen. Anti-sperm antibody indicated if there is sperm agglutination or clumping, low motility and history of testicular injury, increased leukocyte, and in cases of unexplained infertility. Hypoosmotic swelling test differentiate immotile from dead sperm or necrospermia using hypoosmotic environment with 25 millimicron citrate and 75 millimicron fructose. Viable sperm should swell when placed in the solution, while inviable sperm will not affected by the solution. Sperm penetration assay, bioassay of sperm to penetrate hamster egg, help couple to decide the use of IUI if good sperm penetration assay, or use IVF, in vitro fertilization, and micromanipulation if poor sperm penetration assay result. Sperm cervical mucal interaction between the sperm and cervical mucus, if abnormally, may suggest the treatment of IUI, which means intrauterine insemination. Sperm placed beyond the cervix. Chromosomal study, 2 to 15% of patients with azoospermia or severe oligospermia may have chromosomal abnormalities, like Klinefelter syndrome, XXY, is the most common frequent detected. Cystic fibrosis mutation, testing 80% of men with congenital absence of VAS will harbor cystic fibrosis gene mutation. Radiologic testing like scrotal ultrasound, hydrocele, abnormality of peritesticular region, color Doppler used to investigate varicocele. Venography is expensive, invasive, and technician dependent. Main indication, simultaneous percutaneous treatment of varicocele and diagnosis of recurrence of the varicocele after treatment. Transrectal ultrasound imaging the prostate, seminal vesicle, ejaculatory duct, replace the vasography in diagnosis of obstruction. Testicular biopsy and vasography indicated in only cases of azoospermia plus normal hormone profile, or we have to have sperm retrieval for intracytoplasmic sperm injection in azoospermia. And multiple percutaneous fine needle aspiration or mapping of the testis, what's called mapping of the testis, can detect sperm in 60% of men with unobstructed azoospermia. Semen culture. Semen routinely contaminated with the passage through the urethra and thus used in selected situations like history of genital tract infection, abnormal expressed prostatic secretion, or if there is more than 1,000 bacteria per ml of semen or more than 1 million leukocytes per ml. It's called biospermy. Causes of male infertility, either pre-testicular, testicular, or post-testicular. Pre-testicular is due to hypothalamic disease like gonadotrophin deficiency, Coleman syndrome, isolated LH deficiency, isolated FSH deficiency, or congenital hypogonadotrophic syndrome. Or due to pituitary disease like pituitary insufficiency due to tumor, infiltrative process, operation, radiation, deposit, hyperprolactinemia, exogenous hormone like estrogen, androgen excess, glucocorticoid excess, hyper and hypothyroidism, growth hormone deficiency. The testicular causes can be chromosomal like Klinefelter syndrome, XXY, XX6 reversal, XYY syndrome, Noonan syndrome, male Turner syndrome, myotonic dystrophy, vanishing testis syndrome, bilateral anorchia, Sertoli cell-only syndrome or germ cell aplasia, Y chromosome microdeletion, gonadotoxin radiation drug could affect the testis also, systemic disease, renal failure, liver failure, sickle cell anemia, defective androgen toxicity, testis injury like orchitis, torsion, trauma, cryptorchidism, varicocele, idiopathic. Post-testicular causes, reproductive tract obstruction, can be congenital blockage or congenital absence of the vase, Young syndrome, idiopathic epididymal obstruction, polycystic kidney disease, ejaculatory duct obstruction, or acquired causes like vasectomy, groin surgery, infection, functional blockage, sympathetic nerve injury, and pharmacologic. Disorder of the sperm function or motility like motile cilia syndrome, maturation defect, immunologic infertility, and infection. Disorder of coitus like impotence, hypospadias, timing, and frequency. Treatment. The surgical treatment is indicated in varicocele, which is the most common surgically corrected cause of infertility by varicocelectomy, or vasovasostomy if there is vasal obstruction. It needs optical magnification, microsuture, microneedle, and smaller surgical instrument. Ejaculatory duct obstruction can be treated by transurethral resection of ejaculatory duct obstruction, or orchiopexy, pituitary ablation, and electroejaculation if there is spinal cord injury. Non-surgical treatment, specific therapy need to reverse a known pathophysiologic effect. Biospermia, when there is 20 leukocyte per high power field, and we know that sperm possess little cytoplasm, so they are highly susceptible to effect of oxidative agent, like due to infection, sexual and transmitted disease, penile discharge, prostatitis, epididymitis. So treated by, we know that the most common organism, chlamydia or mycoplasma, are common. Treated by doxycycline plus and trimethoprim plus sulfa, and antioxidant like vitamin A, E, and C, or glutathione. Female partner, if there is infection, should be treated. Coital therapy, timing and frequency is important. Every other day around the ovulation is best to decrease the stress, and the sperm reside, as we know, for 48 hours viable in the cervical mucus. Basal body temperature and charting or hormone kit detect LH surge in the urine to determine the time of ovulation. Medical therapy, if there is hyperprolactinemia, hypothyroidism, congenital adrenal hyperplasia, testosterone excess or deficiency, infertility associated with Coleman syndrome, lack of gonadotrophic releasing hormone that stimulate normal pituitary function, can be very effectively treated with human chorionic gonadotrophin 1,000 to 2,000 international units 3 times a week, and recombinant FSH75 international unit twice weekly to replace the luteinizing hormone and follicular stimulating hormone. One can expect to find sperm in the ejaculate after the passage of 9 to 12 months after therapy is started. Individuals with isolated LH deficiency respond well to human chorionic gonadotrophin therapy alone. Anabolic steroids are common and underdiagnosed reason for testicular failure, in which excess exogenous testosterone and metabolite depress have negative feedback on the pituitary gonadal axis and spermatogenesis. Empiric medical therapy, this form of therapy, seek to overcome pathologic condition that ill-defined idiopathic infertility or have unidentifiable but no proven treatment. The anti-estrogen block the action of the normally low level of estrogen on the male hormone axis and result in increased secretion of gonadotrophic releasing hormone, which are the FSH, which stimulate the FSH and LH. Antioxidant therapy, glutathione 600 mg daily for 3 to 6 months, or vitamin E 400 to 1,200 international units per day. And assisted reproductive technique can be used nowadays, which is either intrauterine insemination or in vitro fertilization and intracytoplasmic sperm injection. Thank you.